start recording. Yeah, okay. Record to the cloud. Is it recording?
Recording in progress.
Cool. All right. Okay. Thank you everyone for joining today. After a lot of drama this morning, behind the scenes with broken computers and everything, I am so happy to be here. Introducing Professor Sunny Anand from Stanford. Sunny needs no introduction, actually. And if you're wondering why we anesthetize babies when they go through major heart operations, this is the man to talk about that. So Professor Anand is a pediatric anesthesiologist, an intensive care specialist, as well as a pain specialist from Stanford. And he's going to discuss today a really, really pressing problem in the ICU, from using no analgesia to lots of analgesia, especially opioids. And he'll talk to us about how we can, I guess, rationalize our use of opioids, but not at the expense of comfort for our sick babies. So without further ado, Sunny, over to you. And before you start talking, just a bit of housekeeping rules. I am recording this time. Sometimes I forget to press the record button. We will load the talk onto our Dropbox if everything is okay and no one's doing anything weird in the background. Please type your questions for Sunny to answer at the end of the chat. But if you have a really burning question, use the reaction button with the hand to pause him, and then he'll answer your question. Okay, so over to you, Sunny. Thank you so much.
All right, thank you very much, Julie. This is truly an honor. And I can tell you, I feel a little bit, I feel like an imposter talking to all of these very learned and experienced people who are on the call. I can recognize a few colleagues and few names from the literature as well. You know, I do have a passion for sort of pain in infants, and have spent the major part of my career working in this field. So I was going to talk about opioid sparing, and skirting tolerance in the NICU. Basically, our learning objectives are derived from the fact that there are many sort of indications for giving opioids, and there are many side effects that we see in opioids. Like, for example, in the neopain multicenter trial, we found, you know, prolongation of mechanical ventilation, delayed in feeding, urinary retention. So, you know, we found a few side effects of using in a randomized double-blind placebo-controlled trial, you know, in preterm neonates. So it is not unusual to see some side effects and all that. There may be multiple strategies for either pairing or sparing opioids. You know, so I think there is more and more a realization that there are non-pharmacological approaches like music, like sucrose, non-nutritive sucking, you know, skin-to-skin contact, or KMC as it's called in some countries. Acupuncture, you know, is not very well subscribed in the NICU, but highly effective. And then, you know, there are ways to use topical, local, or regional analgesia, or even spinal epidural caudal anesthesia to, if there are sort of areas of the body that can be blocked. The earlier in the pain networks or the pain system that you can block the impulse from getting into the pain system, the better it will be, the easier it will be to control the pain. And then there are, you know, other drugs that can be used to reduce our dependence on opioids. And that's important because when you use opioids, they will produce tolerance, and when you stop using them, they will cause withdrawal. And tolerance and withdrawal often prolong the NICU or the hospital stay. We need to be aware that opioids can cause hyperalgesia, can cause excitability. And opioid hyperalgesia, as well as a worsening pain state, can masquerade as opioid tolerance. So we need to have some ways of trying to differentiate between these three entities: tolerance, opioid-induced hyperalgesia, and worsening pain states. So let's start at the beginning. Act 1, Scene 1. Pairing opioids in the NICU. Here's a baby, lying just about as still as her doll, and is deeply narcotized. So one option is to try and reduce the number of painful events. That way we don't have to give so much opioids. Routine medical interventions can be scheduled with other care procedures. We can minimize the frequency of blood sampling. I tend to place a sampling line early. If we need 3 or more needle sticks or heel sticks a day, then I will go ahead and place a sampling line of some sort. The newborns, could have an umbilical venous catheter, but often that opportunity is lost. And we have, patients coming in for surgery or other when they're older. And there can be things that are tested on other body fluids, rather than trying to stick everything for blood. Once you've done that, that's at sort of the baseline. Once you've done that, then there are non-pharmacological approaches. So non-nutritive sucking, it reduces pains in heel sticks, needle sticks, or circumcision, immunizations. Swaddling, facilitated tucking, skin-to-skin contact. All of these have analgesic effects. Sucrose is well known, or other sweet solutions are well known to produce some degree of analgesia, but particularly around acute procedures. Acupuncture and acupressure have been tried. There are a few articles published on that. I'm not the expert, so I will not talk on these topics, but there is evidence, and we use it. We use acupuncture in our NICU, for postoperative pain and also for treating opiate withdrawal. The presence of parents at the bedside, music therapy, all of these, are other ways. For example, there was a recent article on music therapy for retinopathy of prematurity screening, but there's also a meta-analysis on, perioperative music interventions in surgery. This included, randomized control trials in children, but also included a large number of infants as part of that. And what they found was that, it's effective for procedural pain, postoperative pain, needle stick pain. It can, there are, these are the number of studies that were involved. Then what are the types of music? It seems classical music and kids music and pop music seem to be the most effective. And then, whether it's speaker or live, or live doesn't make any difference, but speaker or headphones will make some difference. And then, there are ways of rating that were important. Moving on to some of the local, topical, regional anesthetic drugs, these are some of the local topical things. I don't know if it's commonly used now, but Emla used to be, it's a eutetic mixture of lidocaine and prilocaine, used to be very commonly used in Europe and North America. It was replaced by Amitop or Pontocaine, which is tetracaine gel, liposomal lidocaine, and S-caine is actually a transdermal patch, which has an iontophoresis, device built into it. If we're not applying topical anesthetics, then we can do local infiltration. There's several needle-free systems that are available. Be careful because in little babies, you should not go above a dose of 3 milligrams per kilogram. There are other drugs that have been used which are longer acting and have been used in various different studies. These are generally two kinds of drugs. They're the ester anesthetics and the amide anesthetics. And this is sort of the maximum dose. But the overall recommendation, this is from the FDA website, in neonates, it may be safer to halve the maximum dose. So older children can process this. Neonates are more likely to have cardiotoxicity from these drugs. Moving on to how we can spare opioids in the NICU. I think the key issue is that there are a number of drugs, IV or PO acetaminophen, ibuprofen, naproxen, mostly given by the enteral method, ketorolac, which can be given both enterally and intravenously. So these are some of the drugs that have been shown to reduce the requirement for opiates. These you can classify them into the non-specific cyclooxygenase inhibitors and the COX-2 specific COX-2 inhibitors. The key issue is that you should not combine treatment with both these classes of drugs. For example, if if you have someone who's getting naproxen for, say, this is even in adults, if you have naproxen for, say, arthritis and aspirin, for its antiplatelet effects, that's not a good combination. You need to try and avoid that. Because when you combine drugs from these two classes, then you get a marked increase in GI or hematologic side effects. Focusing on the GI types of effects, when you have ibuprofen, this is from a large database of about 2 million patients, but mostly adults. There was a 40% increase in either GI perforation, ulcer, or bleed. But when you combine the ibuprofen with aspirin, this really jumped up 3.4-fold. And similar things when you combine naproxen with aspirin. So it's key. This has been noted in adults. It's not so common to combine these drugs in neonates. So I don't think that's a problem we would have to deal with. Toradol or ketorolac is a common drug. It's post-op analgesic for all age groups. It's very effective in newborns. It does have some opiate sparing effects. Although there was a slight increase in the post-operative bleeding in about 17% neonates, in a post-op sort of study. These were mostly neonates who were within 10 days after birth, if they had surgery and then post-op analgesia with Toradol. Older infants, about 1.6%, and similar rates in older children. There've been a couple of studies in cardiac surgery where ketorolac was used, and there was no increase in the renal function or postoperative bleeding or a need for blood transfusions after surgery. I'm sure you're very familiar with acetaminophen or paracetamol, as it's called in Europe. It's has a similar analgesic efficacy as ibuprofen does. There's no differences in safety and side effects. acetaminophen is metabolized through three different pathways. One is glucuronidation, and the other is sulfation. In newborns, the glucuronidal transferase pathway is not very developed, so most of the drug is sulfated. And then when this pathway or both these pathways get saturated, then it goes into the secondary pathway, which is oxidation, using cytochrome P450 enzymes. And this forms a very reactive compound, the NAPQI, which then starts to bind to mitochondria and nuclear membranes in the liver cells. That's how it causes liver injury. Infants are protected from both liver and renal injury. The reason being that hepatocytes in babies have higher levels of glutathione in their liver cells. And so glutathione, sort of mops up this compound and does not allow it to cause cellular toxicity. There's been several case reports where pregnant mothers had taken a fatal overdose of acetaminophen, and where they had, massive hepatic necrosis. Their babies who were delivered by emergency C-section, did not have that degree of renal injury. The reason why they're protected from renal toxicity is because the sulfate of acetaminophen is more soluble in the urine and can be easily excreted. Giving IV acetaminophen reduces pain scores, particularly after when used for postoperative analgesia. And there's at least one trial. There are a couple of other trials where there was a reduction in the need for postoperative opioids. This was published about 10 years ago, and there were a few weaknesses in this trial design, which I had discussed in this editorial published in the same issues. So it's not like a pain panacea, but it really is something we need to be aware of. And then coming to opioids, they're very popular because they have a wide therapeutic window. They inhibit changes in vital signs. They decrease hormonal stress responses, and huge variances in the dose and frequency of use in NICUs. Morphine is sort of the workhorse. It seems to not work in the setting of acute pain. There are a few studies, for procedural pain or endotracheal tube suctioning where it did not seem to have any effect, but it works very well for postoperative pain or inflammatory pain, so some kind of prolonged pain. It's metabolized to two different compounds. Morphine 6-glucuronide itself is a potent analgesic, whereas morphine 3-glucuronide, and this is the compound that neonates are mostly making, it acts as an opiate antagonist. Morphine can cause histamine release, as you know, has some effects on GI motility, but a less risk of tolerance as compared to fentanyl. So fentanyl is also very commonly used. I don't know, there seem to be NICUs where morphine or fentanyl, it's almost a cultural effect. The reason why it's used very widely is because of the hemodynamic stability, less histamine release. It's metabolized in the liver, very highly effective clearance of fentanyl. Although the potency ratio of fentanyl versus morphine is, 80 to 100-fold in adults, Ruth Guinsberg and others have found that it may not be as potent. So it may be little, it's only 30 to 50-fold. But still much more potent than morphine. in equianalgesic doses. Fentanyl is also lipophilic, so we can use it transdermal or intranasal routes, but recognizing that tolerance will develop rapidly. There are, at least some uses for methadone. I think the key issue is, what is the situation? What, where do you want to sort of apply this modality? It seems to be somewhat more effective than morphine and has fewer side effects. The reason being that it works on mu1 opiate receptors. But it also causes desensitization of delta opiate receptors, and it blocks NMDA receptors. These are receptors that are the excitatory receptors along the pain pathways. It has good oral bioavailability. It's metabolized in the liver mainly by cytochrome P450, the common use is in the setting of prolonged pain or in palliative care, or when you're trying to get off of, a fentanyl or morphine infusion. That's where methadone is very useful. We'll talk a little more about it. There are some unique side effects that methadone has. There are babies that have developed nystagmus, persistent, intractable kind of nystagmus occurs after, the 48 hours but it's not very common. There are a few reports of this, and a couple of reports of a reversible encephalopathy that was noted in neonates who were getting methadone. This was mainly in full-term neonates who were getting methadone because they were born from, opiate-addicted mothers or mothers with opioid use disorder. I should be a little more careful in using those terms. Clonidine is a non-opioid. It potentiates opiate analgesia. It's an alpha-2 adrenergic agonist, and the reason why it potentiates the opioid analgesia is that the sub-receptor mechanisms are the same. For example, this alpha-2 adrenergic receptors will downregulate your G protein. It's the inhibitory G protein, or it actually activates the GI2 alpha protein, which is what the opioid receptor also does. And so when you have two drugs with a similar sub-receptor mechanism, you get potentiation. It's an analgesic. It's also used commonly as an antihypertensive. It's very versatile, can be given through many different routes. And, it's usually an adjuvant for analgesia. It can also be given for opiate withdrawal and for spasticity in babies with cerebral palsy. There's several studies that have used clonidine. However, some of the hemodynamic effects are, can be a limitation. And that's where dexmedetomidine comes in, because it produces analgesia, anxiolysis, and sedation, but it is more specific for analgesic sedative effects than the hemodynamic effects. And that's because it activates, not all of the alpha-2 adrenergic receptors, a few subtypes of those, as well as opioid and GABA receptors. It's from pharmacodynamic studies, excuse me, the sedative plasma levels are slightly lower than the analgesic levels. So you will see some degree of sedation before you start to see the analgesia. And there have been 11 randomized controlled trials where dex given during surgery reduced the need for opioids, and the postoperative pain scores. So there's a meta-analysis published. Ketamine, I think, is a very versatile drug. It causes intense sedation, analgesia, and amnesia. It also increases secretions and muscle tone. But it's the only drug that does not decrease the heart rate and blood pressure, and it does not suppress the respiratory drive. So, sorry. So it is a very useful drug, particularly in the setting of neonatal sepsis or septic shock, or in the setting of, say, congenital heart disease, particularly duct-dependent lesions like hypoplastic left heart syndrome or others, where you're concerned about hemodynamic stability. Ketamine is a very good drug to use. We also use it very commonly out on transport because it does not suppress the respiratory drive. So there are several meta-analyses showing that it reduces pain intensity and need for non-opioid analgesia. There were no clear opioid-sparing effects, but it can be used both intravenously and through regional anesthetic techniques. There are other studies in the younger infants and children where it has shown some opioid-sparing effects. This was in the two meta-analyses on postoperative pain, but there's a fairly good amount of data to show it can have some analgesic effects and reduce the need for opioids. So why are we so focused on trying to reduce the need for opioids? Because they are very tolerogenic. Kids, babies particularly, are susceptible to the tolerance. It develops very rapidly, and there are some sort of neurophysiological reasons why it develops more rapidly in infants. So what are the factors affecting opioid tolerance? It's the duration of opioid receptor occupancy. We found that opioid tolerance peaks at two particular points. So if you're using opiates, you will have a peak of opioid tolerance at about 4 days. And then if you continue using opioids, you get more tolerance peaking at about 10 days. And that was shown in what's called the MOTIF study that we had published about 7 years ago. Opioid tolerance is faster with continuous versus intermittent dosing. It also depends on which drugs are being used, like morphine is less likely to produce tolerance. There are some gender differences. So at least the older children and adults, the girls seem to get tolerant more quickly than boys do. And that's both in pre-pubertal and post-pubertal populations. Early developmental stages, we've already talked about. Neonates make more M3G, which is an opiate antagonist that contributes to tolerance. And then there are some interactions with other drugs, which I can talk about. So here's some of our studies from the results from the MOTIF study, where basically we found that there was, compared to adolescents, 1 to 10-year-old children had slightly higher, and infants had a slightly lower incidence of opiate tolerance. For this study, we had defined tolerance as a doubling of the total opioid analgesic dose required for any 24-hour period. So it was more of an operational definition, while pain scores were being maintained at the same level. Oops, what happened? Okay, here we go. So what is very interesting in the study is that if the primary opioid being used is morphine, it's about half as likely to produce opiate tolerance as compared to fentanyl. But when either one, morphine or fentanyl, is combined with midazolam, there's a 5-fold increase in the incidence of opiate tolerance. Whereas if it's combined with lorazepam, then there was no, it was not a significant factor in this logistic regression analysis. Of course, if you've used an opiate infusion for longer than 7 days, then there is a very high likelihood of developing opiate tolerance. So how do we come up with opioid tolerance? It's basically diminished analgesic effects from the same dose which was previously being given. And this can masquerade as different things. It could be a worsening pain state. For example, particularly in children who have metastatic cancer, bone cancer, their pain state can get worse. And so that disease progression may be the need why the opioids are not effective. There can be neuropathic pain mechanisms or enhanced metabolism, for example, in burn patients. So in this, if these are the underlying factors, then you need to consider escalating opioids, add non-opioids, treat specifically for the neuropathic pain or other mechanisms. On the other hand, it could be opiate-induced hyperalgesia. When opiates have been used for 2 or 3 days, they tend to sensitize the primary afferent neurons. And they also activate dynorphin and central glutamatergic systems. So these are all excitatory systems in the spinal cord, with the result that you get hyperalgesic. And so, how do we know that this is hyperalgesia versus, tolerance? Usually, the pain or the hyperalgesia is not localized. For example, say you have a child with, a hernia repair and, or a gastroschisis, and their hyperalgesia is mainly located to their abdominal area, say after gastroschisis repair. But once they've been on opiates for 2 or 3 or 4 days, they start to be hyperalgesic in any other part of the body which was not previously affected. And in this situation, tapering of the opioid doses can actually produce better analgesia. If you add an NMDA antagonists, memantine or ketamine or other things, then those specifically block the mechanisms of opiate-induced hyperalgesia. You can also try longer-acting opioids like methadone or etorphine, or a rotation of opioids, because you have different receptors being stimulated by different opiates. And then finally, if you've excluded these two, this is when we can say this is opiate tolerance, which is basically dependent on 2 different pathways. One is desensitization of the opiate receptors. The other is superactivation of the cyclic AMP pathway within neurons. So the therapeutic approaches over here could be escalating opiates, longer-acting opiates, adding non-opiate analgesics, or trying drugs that can prevent or delay opiate tolerance. Now that's an area of, a hot area of research, and how we should do that, is quite controversial and active area of investigation right now. So this is just a summary of all the other mechanisms. I've sent these slides to Julie, so you can just look up. This is more academic interest than anything else. But I think what's important is to recognize that by looking at the mechanisms, there may be ways we can think about preventing, opiate tolerance from occurring. So let me orient you to this, very sort of busy, intimidating kind of slide, where, here's your opiate receptor. It's binding to here's your opioid agonist, and it's binding to the receptor. So normally what happens is when it binds to the receptor, most of the receptors live in the inhibitory mode. So when the agonist binds to the receptor, they turn on the GI alpha and the GO protein. The GO protein, interacts with these ion channels in the neuronal membrane, increases protein kinase C and, sort of G protein receptor kinases, which causes a desensitization. So the neuron gets hyperpolarized. At the same time, there is decreased cyclic AMP, which leads to a decrease in the action potential duration, which is then seen as analgesia. But after opiate drug has bound to the receptor for a while, what happens is that this receptor can shuttle from the inhibitory to the excitatory mode. And how that happens is through a membrane protein called GM1 ganglioside. When it gets uncoupled from these inhibitory G proteins, and that couples to a stimulatory G protein. And this stimulatory G protein increases cyclic AMP production, activates protein kinase A, and then further increases the GM1 ganglioside and further causes, sensitization of opiate receptors. So you don't need all the opiate receptors to flip from inhibitory to excitatory mode. Only about 10% of receptors, if they are flipped over, they will supersede the inhibitory effects of the opiate receptors. And so this is a pro-nociceptive pathway and one of the key mechanisms. So what was noticed by Stanley Crane and his postdoc, Yang Shen, was that receptors that are in the inhibitory mode can be blocked by nanomolar concentrations of Narcan or naloxone. Where do I go back? Here we go. Whereas receptors that are coupled with the stimulatory G protein, they are completely blocked by picomolar concentrations of naloxone. So this is a 1,000-fold lower concentration, than what is required. So, you can use various different strategies to sort of prevent or delay opiate tolerance. One is you can have, nursing-controlled analgesia, rotation of analgesics, use of epidural, neuraxial opioids, daily interruption of analgesics, which is really not practical in the NICU. But you can also combine opioids with NMDA antagonists and ultra-low dose Narcan. And so, or you can also combine with methadone, which is an NMDA antagonist. So let me talk about that briefly. So ketamine is a drug that can prevent or delay tolerance. We use generally a non-sedative and non-analgesic dose. For analgesia, you need 1 milligram per kilo per hour, but we use a non-sedative or analgesic dose, 0.1 to 0.2, and we found that it decreases the need to escalate the opioid that we're using. And that's because it blocks the NMDA receptor, which is part of the tolerance-producing mechanisms. Ketamine has been used as an adjuvant to opioids, several randomized controlled trials, and it improved the outcomes in terms of pain scores, the first request for analgesia, total need for analgesia as well as opioid side effects. You can combine morphine with methadone. Methadone actually reverses the tolerance. This was a postdoc in my lab who showed this, 20 plus years ago, because methadone causes desensitization of opioid receptors, of the delta opioid receptors. So that leads to G protein uncoupling, and it also has NMDA blockade effects. So because of that, combining morphine or fentanyl with methadone at the same time can reduce your need for escalating these, shorter acting opioids. And then ultra low dose Narcan, as I had mentioned, it can block the GS protein coupled receptors. So it avoids supersensitization of your cyclic AMP pathway. And the drugs that the dose that we use is 0.1 microgram per kilo per hour. So just a good way to remember is you need 10 micrograms per kilo to overcome respiratory depression due to opiates. That's what you need in the delivery room where the mom has received a big opiate dose during the cesarean section. You will reduce 1/100th of that dose. And the reason why we use 1/100th is because it's relatively less lipophilic. So getting into the brain, we need slightly higher doses. So you've tried to prevent opiate tolerance, you couldn't, and now you have to get off of the opiates in order for the child to leave the NICU. And you're often faced with neonatal opiate withdrawal syndrome. So this is the AAP recommendations published 3 years ago. And basically they call for supportive care in terms of encouraging breastfeeding, decreased sensory stimulation, high calorie feeds, hydration, sleep cycles, etc. And then, if this is not enough, then there is a need for replacement of opioids and, weaning the drugs slowly. That's sort of the main term. In the ICU, though, if there is short-term therapy, so up to 7 to 14 days of opiate therapy, then you can wean the drugs within 5 to 6 days. But if there is long-term therapy, longer than 14 days, then you need at least 10 to 12 days to wean those opiates. And this is a protocol that's been published several years ago. There are other drugs that are being used to, overcome the symptoms of opiate withdrawal. Buprenorphine, I've already mentioned, clonidine, dexmedetomidine, propofol, and gabapentin are other drugs that have been used. These are both experimental agents, and so I don't think we can use those in neonates just yet. So just to conclude, and I wanted to have sufficient time for questions, for pairing opioids, I think the frequency and duration of painful events or stressful events can be reduced. There are several approaches like non-nutritive sucking with sucrose or music therapy and local topical regional anesthetics. Acupuncture is fairly effective, at least in our hands. For sparing opioids, combine the drugs with some other kind of analgesic, including the NSAIDs or acetaminophen or alpha-2 adrenergic agonists. And then for skirting opioid tolerance, we need to treat opioid-induced hyperalgesia, differentiate it from worsening pain states, but also consider either procedural changes such as nurse-controlled analgesia, rotation, daily interruption, or combining with either ketamine, methadone, or ultra-low dose Narcan. So I'll close at this point and see if we can. Okay. Yeah. So happy to
Okay,
take
thank you
questions.
so much. Yes, thanks, Sunny. Great talk. There are comments and questions. I've been private messaging people, and we will start with Dr. Hari Ram from India. I'm not sure whether you know Dr. Hari Ram. He
Yeah.
says that they use dextrose 25% for invasive procedures. What are your thoughts on that?
Yeah, it's very much the same. You know how the dextrose and sucrose work is that they activate. There are cells in the periaqueductal gray matter, which are the on cells and the off cells, and so basically your gustatory receptors go through the glossopharyngeal nerve to the brainstem, and they activate the off cells in the periaqueductal gray matter. And that's what decreases the transmission of your, from spinal to supraspinal transmission of the pain impulses, and that's why it produces analgesia. So 25% dextrose is just as good or as effective as sucrose, and so really no issues with that. And there are good trials, there are good randomized trials to show that it is effective.
Thank you. I think one from Richard. Richard, if you want to unmask yourself. Look, I think what Richard is saying is that ketamine and methadone is infrequently used in NICUs, but when they hop over across to your unit, Sunny, in the children's ICU, then you guys throw these medications at them. Should we be changing our practice?
Yeah. So I think what is important to note is that there was about 25 years ago, there was a big controversy surrounding ketamine, and it lasted for about 10 years. And basically, there was a study published in Science in the January issue of 1999, where John Olney and group from Washington University in St. Louis, they had given ketamine or diazepam, NMDA antagonist drugs in very high doses to newborn rats. And what they found was that it causes a lot of apoptosis. And they found that giving ketamine causes apoptosis in rats that are 7 days old, but not in rats that are 3 days old or 10 days old. And if you look at some of the, there are some very beautiful studies shown in terms of genetic regulation of neurodevelopment in the rat. And there's a big change that occurs right at 7 days of age. There's a big change. I don't know, I can sort of see the figures in that paper. But what was remarkable was that after this came out, the FDA wanted to ban ketamine use in children, and particularly in infants and neonates, until we pointed out that they had used 140 milligrams per kilogram of ketamine in those newborn rats. So I have never even dreamt of using 100. That's 100 times or 140 times the dose that I would use. So clearly this was a toxic effect. And in fact, we published some studies where, so in John Olney's studies, they gave the ketamine in the absence of any kind of painful stimulation. There was just they did not monitor oxygen, glucose, feeding, body temperature, all of those things were not monitored in those baby rats. On the other hand, what we did was we gave ketamine in newborn rats 2.5 milligrams per kilo in the setting of inflammatory pain. And this was a paper published in Pediatric Research, I think 2007 or 2008. And what we found that actually it had the opposite effect. It prevented excitotoxic cell death. In rats that got the ketamine so it prevents some of the cellular cell death changes that are occurring as a result of prolonged pain. So I think because of that, ketamine got a lot of bad press. And since then, there have been 3 studies. There was one study called the PANDA study, published from Columbia. There was another study called the General Anesthesia Study. It was actually the gas study. And then there was a third study which showed no effect from giving anesthetics in early age groups on their long-term outcomes at 2 years and 5 years, no change in cognitive, behavioral, or other long-term outcomes. So I think because of this, there's a lot of concern amongst clinicians, rightly so, that, should we use ketamine or not because of the neurotoxicity. And I think the key issue is that we should use these drugs. We should use them in the setting of an IRB approved study or a hospital research committee approved study. And I think I can go over some of the mechanistic aspects of what ketamine does in the developing brain. But I think it's clearly demonstrated now in multiple species and in multiple different experimental settings, where the effect of ketamine is, when given in smaller doses, is neuroprotective. When given in larger doses, very large doses, is neurotoxic. And we even did a randomized control trial in babies having cardiac surgery. And we published that, where ketamine was seen to have neuroprotective and anti-inflammatory effects in the setting of cardiopulmonary bypass and surgery. So,
wow, okay. Sorry, keep going.
Yeah, that's I can talk at length about this, but I think the key issue is that ketamine and methadone are both very useful drugs, and if there can be studies that are designed to use those drugs, I think we will start to get more information. There is already some amount of information, but there are no randomized control trials. So that's what I'm advocating for is, design a study. Let's get because there is no data, no high quality data, I think we have a moral imperative to try and get that data. And that's what I would recommend.
Mm-hmm. So so Richard says that answers his question, and time for considering a practice change. Tim Cochran, are you happy with that answer? He's asked about neurotoxicity or long-term neurodevelopmental effects, especially from ketamine.
Yeah, I think there is at present there is no data in human infants or in human children that shows the neurodevelopmental effects, long-term effects from use of ketamine.
Okay, so what you're saying is ketamine, there's no evidence that ketamine is harmful in the long term. Okay. Okay.
And
Right.
there is good evidence to show that, you know, repetitive pain, and to some extent, you know, excessive use of opioids can be harmful in terms of long-term neurodevelopment.
I don't know about
So
everyone on the talk, but we have some babies on 3,000 hours of opioids. So that's a very scary number.
yeah.
All right. Sopapan is asking from Thailand, is asking another question, another track now. Intranasal fentanyl in newborns. What are your thoughts?
So I would say, you know, we use it. It is used, but be very careful with the dose and the rapidity of effect. You know, very quickly, as soon as you give the nebulized fentanyl, the baby will stop breathing. So you need to be ready to be able to handle that. And I tend to recommend smaller doses. So instead of the 2 micrograms per kilo, we use you know, half or 0.75 microgram per kilo, and that would be a reasonable. If you have no IV access and you know, you're really stuck, it's a sort of any port in a storm. So intranasal fentanyl can be considered in those situations.
Okay. And something dear to our heart is minimally invasive surfactant treatment. We've got Peter Dargaville online as well. Hello, Peter from sunny Tasmania. What are your thoughts about sedation or analgesia? This
For
is
the surfactant use?
yes. So minimally invasive from Suresh
Yeah.
is a procedure where we give surfactant with a catheter in and out, and there's a lot of discussion in the neonatal circles about the type of analgesia or whether the baby should have any analgesia during this procedure, because we want to keep them breathing so we don't have to intubate them, right? Yeah.
My guess is that this procedure is so short and so brief, and the critical thing is that you want to keep them breathing. So my bias would be to use nothing, or at best maybe use a lidocaine spray.
Okay.
Yeah, and we use this frequently in the operating room. You know, we'll use a 2% or a 4% lidocaine spray. The 4% in the older children, so you know, 10 years and older. But in the younger children, we use 2%, and you can just spray. You can directly spray the glottic area, and that gives you analgesia. Within seconds, you will have some degree of analgesia, and when you pull your catheter out, then you know it tends to go away pretty quickly also.
All right, we've got Peter Dargaville online in sunny Tasmania. Peter, what about your comments about that one? You're the Miss guy. Is he able to unmute himself? No, he's having lunch. Anyway, when you get back online, Peter. All right, so a couple more questions. We've got one from Shripada Rao in Perth. He's very excited because he's been reading your articles in pain since his registrar days. All right, so we won't go into the timeline there, Shripada. Thank you. If there is one drug, you've given us a whole list of medications to be tested in an RCT to reduce opioid withdrawal in chronic NICU patients, which one would it be? If you had a choice, Sunny, out of your little basket of medications?
What I would prefer to do is have a study on ultra low dose Narcan. I think that would be the, that would be the best way.
Really?
Yeah.
Oh, right. Okay. I've never heard of ultra low dose Narcan. Maybe we can talk to Srini Bolisetti. He looks after the Australian neonatal medicine formulary. He's online now. And Srini, you probably have a lot of homework to do after this talk. Hello, Srini. He's gone.
About
yeah. Peter is online. Peter, can you just quickly unmute and
yeah, hi
talk
Joy,
about
hi Sunny. Sorry I couldn't unmute before.
Sure.
I'm interested in those comments that you made about use of nothing as the approach for minimally invasive surfactant therapy, and that indeed has been the approach, other than using non-pharmacologic measures, sucrose and intraoral sucrose and swaddling. But I would be curious to know whether you have experience of using dexmedetomidine, which is starting to be considered and used in neonates and in preterm neonates, and whether you think that offers some potential for giving something that can produce some tolerability of the procedure but maintain breathing.
Yeah. I think that's a very reasonable approach. There are at least 3 randomized trials of dexmedetomidine use in neonates. If I can recall correctly, they were mostly in the setting of mechanical ventilation. They were not used for this. But Peter, if that is something that there is reasonable equipoise, do even a pilot study of, say, 100 children, where the dexmedetomidine is given, with versus a placebo, would be very useful, and it'll clearly document. I think it's a very reasonable drug because it does not. In fact, there is fairly good data in non-clinical or experimental studies to show that it is neuroprotective. So dexmedetomidine seems to have some neuroprotective effects, but and it does not suppress respiration. You're absolutely right. So I think it's a reasonable drug that can be used in this situation.
So Peter, you're talking about dexmed for short procedures or for longer term analgesia?
No, my question was specifically in relation to surfactant delivery via a thin catheter.
Okay.
Yeah.
Yeah, it's certainly useful, a worthwhile question. Yeah, definitely. Well, unfortunately, we are very over time. And I want to thank Sunny for this fantastic talk. It's certainly opened up our eyes to many potential avenues for analgesia in our NICUs. I've got his slides on PDF, yay, and I shall share that if that's okay, and as well as this recording. I remember to press the record button this time, thank God. All right. So any more questions? I'm sure Sunny will be happy to answer on email, but it's very late now for you, Sunny, and you've just come off call, so you must be exhausted.
Well, the good thing is I can get off and have dinner because.
Oh, fantastic. Yeah.
Anyway, but thank you for giving me this opportunity. I've really enjoyed. I think the having this conversation and looking at the comments and the questions. Certainly, I would like to encourage people to work in this area and do the trials. It's hard work, but it's tremendously satisfying because the entire field will benefit going forward.
Thank you very much. And I'm glad the computer's fixed. All right.